All right, so we are back with another PCBH corner, and we have a phenomenal guest with us, Bob Rosenbaum, and just so excited to be having this conversation with Bob, and for anybody listening to hear what he has to say. Bob has had 40 years experience as a neuropsychologist, psychotherapist, and behavioral medicine specialist. He received his PhD in clinical psychology in 1980 from Boston University and was trained in neuropsychology by Edith Kaplan at the Boston VA. The other thing that's really awesome about Bob is the work that he's done with single session therapy. And I've had the honor of attending multiple trainings, and I still remember at the PCBH forum before CFHA, and just kind of hearing Bob talk and just kind of having this moment of like, this is it. This is it. So that's all true story. And that's why I'm so excited to have people listen to what you have to say today. So as Bob and I had talked before the PCBH corner about a little bit that we wanted to go over with you all was whether you're in PCBH working as a behavioral specialist in a different integrated care setting or using the philosophy of single session therapy, you kind of embrace this idea that you can get something done in a non-traditional amount of time, for whatever that means, and you learn to be in the moment and do what you can. And so often in our field, it's kind of things folks will kind of think about the clinical work on there being a cap on what can be done in a visit. And there's often a focus on what are we going to do in visit 2, 3, 4, 5, 6, and less on what can we do now. So my question to you is, if folks think that there's a cap on what could be done in a visit, what's your take on the caps that maybe we place on what could happen during a visit?
Well, the cap that exists on what can be done in a visit depends on what cap you're wearing. So if you happen to be wearing this cap, which is what I wore on Halloween with my kids, you're in a trick or treat mindset, which is if the client doesn't treat you by changing the way you want them to change, if they don't give you a treat, you're going to trick them into coming to therapy in the future because they really need it.
Because they really need it, right?
That's right. They're not going to feel very good about that. If the cap you're wearing is, this is one I picked up in Nepal, and it's a traditional Lama cap. So it's a very spiritual cap. But if you get all spiritual on a client who is not at all into spirituality, they're going to go, what are they talking about? What do they mean? This is the meaning of my life is important or something like that. I'm just here because I have a cough, for heaven's sakes. Just help me with a cough. I mean, the doctor says it's not, it's all in my head, and it's not in my head. It's in my chest, in my lungs. And on the other hand, I've seen many a person who comes in thinking only in terms of the cough, and it can become literally a religious and spiritual experience where they go, oh my gosh, you mean how I feel has something to do with what I'm doing in my life? Which, I mean, as therapists, we kind of assume that, it all sort of fits together. Most people don't think that way. Most people don't see any connection between what they're doing in their life and what they're experiencing in their bodies. I remember seeing one client who came to me. This was a single session, even before we had single session therapies identified. But she was a nice woman of Irish extent, and she came because she was so jittery all the time, and she came and she was literally sitting there like this, and I'm just so jittery, doctor, and I've been to the doctor and they've checked my blood pressure and they've checked my this and they've checked my that. And I talked to her about any stresses in her life, and couldn't really find any. And I checked any problems with her family or anyone else upset, and medically she was all clear. And, well, do you drink caffeine? No, doctor, I don't drink caffeine. And we came up with nothing whatsoever. And towards the end, I remember saying to her, okay, let me just be sure you don't drink caffeine. You don't drink any coffee. No, doctor. You don't eat chocolate. No, doctor. You don't drink any tea. Tea? Doctor? Tea has caffeine? Well, yes, it does. Oh, well, I drink tea, doctor. Well, how much tea do you drink? Well, I like a strong cup of tea, so I always put 2 tea balls in. Oh, and about how many cups do you have a day? Oh, maybe 20, 25 cups. I think we found your problem.
Oh my goodness.
But, the degree of disconnection, I'll give another example. This is an extreme degree, and it came with the client who was too good of a client. Now, this was a few different sessions, but this was someone who was referred to me because she had been in an auto accident. And it was a fairly minor auto accident, and I would see a lot of people with whiplash injuries and whatnot, and there's all kinds of controversies about whether whiplash causes any kind of cognitive sequela. But after that accident, she just couldn't work, couldn't leave her house, was scared, had aches and pains, and of course she'd had all of the workup for all of the medical stuff, and had cost the medical center a whole lot, and everything's negative, and it's 2 years later. And I was meeting with her, and she was an emigre from Cambodia. And as we were talking, I just said, so you came from Cambodia. At that time, there'd been the civil war in Cambodia. And it turned out she'd been through the killing fields. And quite a few of her families had been massacred, in terrible trauma. And simply saying to her, oh, wow, well, that must have been quite a shock. And of course, that's what she experienced. And, the connection between being jostled and the killing fields almost immediately led to a decrease in symptoms, decrease in the depression, just being able to talk about it a little bit. But she did still have a driving phobia. And so we did, this was maybe a 5 or 6 session therapy. So we did a kind of standard desensitization. Okay, get in the car, breathe, relax. She'd close her eyes, relax, fine. Okay, get in the car, put the keys in, don't move the car, breathe, relax, okay. Turn on the car, breathe, relax. We finally got to the part where she turned on the car, put it in gear, and actually backed up a few feet. And I got a quote from her, oh, doctor, terrible, terrible. Oh, what happened? Oh, I'm so scared, got in the car, backed up, hit something, oh, how, and I'm thinking, how could she have hit something? And she came in and I said, so take me through what happened. She said, so doctor, I do what you say. I get in car, I close my eyes, I turn on car, I go into gear, and I back up. She didn't open her eyes. The idea of opening your eyes makes a difference.
Turns out.
When you're driving. And actually, almost everyone who we see, and all of us to some extent, we go through the world like this. And we don't open our eyes. And we don't open our eyes to what might be obvious to other people, but is not obvious to us very often. And sometimes in a session, you can say something or ask a question and people will go, what? I just never thought of that. And it can be as simple as that. And I really have seen people have life-changing experiences within a session. Now, that doesn't happen all the time, and more often it's much less dramatic
Right.
than that. But if we think it's not going to happen, if we go in with an agenda of, oh yeah, I heard this person is depressed, so I've got to deal with their negative thoughts,
Right.
their rumination. Well, maybe you can do with that, but that might not be with what the person's really dealing with. And it just won't work. And then you'll get frustrated.
How, let me ask you this. How, as a clinician, have you prepared yourself to go into each encounter, visit, session, whatever we want to call it, clinical encounter with somebody, to just remember to be in that curious mode and to not put a limit on what can or can happen? Is that from the research that you had done? Is that from personal experience? And for those BHCs or folks out there, any advice for them to get into that state of mind of like, let's, a moment can happen at any time. And it's not always like that, but let's not put limits or caps on what can happen.
Well, when I meet with someone, my main interest is not in accomplishing something. Now, this might shock you or your listeners, but the real transformation came when I'd been working for, I don't know, maybe 10 years or so. And I was starting to burn out. And I was starting to feel, so I'm going to see one more depressed patient, one more anxious patient. And gosh, I'd been through graduate school and training and all of this, so I could spend the rest of my life listening to other people's problems. I mean, something was wrong with this picture. And I just said, that's not okay. I want to enjoy my life. I want to appreciate my life, and I spend a lot of time working. And if I'm not enjoying working, maybe I need to stop. And so I started a practice of, whenever I met with a client, I would have them go into the room first. And that's pretty common in behavioral medicine, where they're in the exam room and you go in and meet them there. But in any case, they were in the room. And before I entered the room, I'd pause and I'd say, okay, how can I enjoy myself during this next meeting? And a lot of people said, what? You asked yourself how you could enjoy yourself? That's not what you're supposed to be doing. You're supposed to be accomplishing something.
Right.
But what I found was, and this was not always easy. I'd be stressed out or something. So just stopping, going, okay, Bob, you're feeling pretty awful at the moment. Take a few breaths. How can you go in and enjoy yourself? Sometimes I know the client beforehand, And it would be, oh, take this as an example. I did a project working with folks who come into the emergency room with panic attacks. And as you know, ER docs hate this. They just, whatever you do, get them so they don't come back.
Right.
Right. And you know, okay, they're going to be going, I can't, the doctors don't know what's, I'm having a heart attack and nobody's listening to me.
Yeah, and the doctor's like, the physician's like, all, you know, everything's normal. So it's not a heart attack.
And so it's really easy to go into that going, okay, how am I going to convince this person that they're really not having a heart attack? Doesn't work. And so if I'd say, how are you going to enjoy yourself, Bob? I'd then reply to myself mentally, there's no way you're going to enjoy yourself. You know what's going to happen here.
Okay.
And I'd have to say to myself, wait a second, you don't know what's going to happen here. Everyone's a little different. You can find a way to enjoy yourself. I mean, that's my job, is to find a way to enjoy myself. So I'd go in with that mindset. I wouldn't always succeed, but the key point here is it helped me go in and be interested and curious, and I'd be looking for something to enjoy. So for example, if you were the client and you're sitting there and you're, one of the first things I'd notice is, wow, that's a really interesting pin that you're wearing. I mean, I can't see exactly what it is, but it's got all kinds of colors and an interesting design. And I wonder what that pin is. And that would be part of my diagnostic workup, so to speak.
Right.
Because someone who wears that pin has a mind that responds to color and design.
Oh, interesting.
You know, you wouldn't be wearing a pin like that otherwise. You'd be wearing something duller, or it just wouldn't have those colors. So I know something about you. And of course, at the moment, you're and
right.
you're worrying about your breathing and whatnot. But if I can somehow find a way to access that part of you which responds to color, that part of you which responds to shape and design, and I'm instead of saying, "Are you having trouble breathing?" I might say, "Is your breathing round, or is it like this? You know, like on a little button." And she says, "Oh, it's so jagged right now." I say, "Well, let's see if we can make your breathing more round."
Oh, interesting.
You know, and they'd probably go, "Huh? What do you mean? What do you mean?" I said, "Well, you know, your heart's kind of round. It's not exactly round, but the blood goes round and round. And even though you're having trouble breathing, the blood is continuing to go round and round, isn't it? I mean, do you feel at all dizzy or faint or lightheaded? You know? And if I think they are, and they go, yes, 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 yes.
Yeah.
Go, oh, well, that's a sign that the blood's going round and round, but maybe a little too much blood's going to your head. You know? So you're going in and you're trying to find something about the client that connects to something you know a little something about.
Right.
How bring them together, and at the end of a session, it's not that uncommon. Actually, one of the things we found in our project was one of the most helpful interventions with panic attack clients was to have them stand up and feel their feet on the floor.
So really
Not
classic
breathing,
grounding exercise.
yeah, literally grounding themselves and feeling their feet on the floor and see how their weight balanced. And then they'd be engaged with something else. And instead of trying to get them to relax, I mean, you know, the worst thing you can do to get to help a person relax is to say, okay, relax.
Right.
I mean, that's
Right.
just the worst thing to do. Because then they can't relax and they can't breathe and then they get more scared. So you have to get out of that time frame. But it's not uncommon for a person after some kind of intervention of that sort to go, wow, I mean, it seems like what I'm thinking up here and what I'm feeling, that they seem connected somehow. You know, that's not uncommon.
Right.
That's life-changing.
To have them experientially recognize the link, and you demonstrated that with them, and
Yeah,
that
yeah.
you know, that's not time contingent. That's not saying, okay, well, we're going to have you come back and enroll into therapy. It's what you were doing right then and there in the emergency department in
And
that
and
case.
and part of it is, if I can enjoy being with a client, I can send a message. This process can be enjoyable for both of us. I mean, you might actually get a kick out of this, you know,
Uh,
which is not what the client's usually thinking. And also, most of the people who we see feel kind of cruddy, and they usually feel kind of cruddy about themselves and worried about how their feeling is affecting other people around them. And to have a sense that the other person is genuinely enjoying them, they like that the other person's genuinely interested in them, they get more interested in the process,
I
and
was
they
gonna
feel a little better, and you start working together as a pair rather than, okay, you're here and I'm going to find some magic thing that I'm going to do to you,
do to you. Yeah.
you know, and you're going to walk out of here feeling better. That just doesn't work.
I was going to ask, when you started kind of taking that approach of, and I know you had said previously in other trainings about finding something interesting about somebody, enjoying them, being genuinely curious about them as a person. When you started doing that as a clinician and letting go of this idea that it was your job to fix people, what impact did that have on the burnout? What impact did that have
Oh,
on your ability? Actually, yeah, the your own burnout, but also what did you see in the patients?
well, I have been burned. I have not burned out yet. I have stopped burning out. um, and the clients relaxed because there wasn't, I think, aside from not, from feeling that this is a person who's genuinely interested, um, they would feel um, that there wasn't a pressure on them to do something. And very often the pressure to get better makes us
Mm,
worse.
right.
And there's, you know, like I work a lot with patients with chronic pain, and the hardest thing in working with patients with any kind of pain, chronic or acute, is to help them not fight the pain, because fighting the pain always makes it worse. Now, it's completely natural to fight the pain, but if something is, if I've got pain here and I walk like this, well, pretty soon I'm going to have pain here as well, right? And pain
Right.
here, and and so usually one has to address the fear that goes along with the pain, uh, and there's various ways of doing that. Sometimes it's a question of noticing other parts of the body or other things one can do with the mind. But to just go, it hurts. And actually, the most common thing with chronic pain patients is they'll have had a doctor say to them, it shouldn't hurt so much,
Yeah.
you know, and to just go, this hurts. This hurts. And is it physical? Is it psychological? Doesn't
matter.
It hurts. And just to have that acknowledgement, very often a client will go, yeah, duh. And often the first thing that you'll get is with that is, well, why would I be coming in here if it didn't hurt, doctor? I mean, yeah, why are you saying the obvious?
Yeah, how do you respond?
Yeah, and you say, well, I might say something like, well, I'm saying the obvious because I know it hurts and you know it hurts, but nobody knows exactly how it hurts except you.
Mm.
And I often say, you know, I've had chronic pain and I deal with pain frequently for myself, and other people don't quite understand. So yeah, it hurts, but how does it hurt and where does it hurt? And you're the expert here.
Right.
And I can help you because I'm an expert too, but you're the expert on your body.
Right.
Let's just start from there. Nobody else. I can do CAT scans, I can do MRIs, I can do EMGs. I've got all this technology. It's not going to tell me how it feels.
They probably never have had another person in their life say something like that.
Yeah. And it's not like it's terribly profound, but it is profound. So it reminds me, we often tell people how they should feel, both as therapists, but as family members. And, it shouldn't feel that way. Oh, you don't know what's good. You don't know what's good for you. I mean, how often does that get projected? And the idea that you're the only one who can know what's good for you, but it's not so easy to know what's good for you. You have to get to know your body and mind pretty well. I mean, I've been working on this a long time, and I still often make mistakes. And that's because our body signals are often a kind of misleading, which is another thing that most people don't know.
Right. They're like, it hurts, so it must be broken or whatever. And that's not always the case, as we know from the copious literature. Yeah.
Yeah. And so Milton Erickson, who I have mixed feelings about, I mean, he certainly could be brilliant and he certainly could be incredibly manipulative. But he used to tell the story about two farmers and a donkey, and one farmer had a donkey, and if he wanted the donkey to move forward, he'd say, "Donkey, step forward," and the donkey would step forward. If he wanted to step back, he'd say, "Donkey, step back." The donkey would step back, and the farmer next to him says, "That's such a great donkey. I want to buy him from you." And so the other farmer gets the donkey. He says, "Donkey, step forward." And donkey just stays there. Farmer starts pulling on him, pulling on him, pulling on him. Doesn't move. "Donkey, step forward." Pulling on him, doesn't move. He goes to his neighbor. He says, "You sold me a lousy donkey. He's not following me." And farmer says, "Oh, hold on." And he comes over. He looks at the donkey. He looks at the farmer. He grabs. He goes to the donkey and goes, "Whomp!" He says, "Donkey, step forward." And the donkey steps forward. And he turns to the farmer and says, "He listens, but first you got to get his attention." Now, I'm not suggesting you whomp a patient, but you need to do something a little unpredictable, something that they're not expecting, which is kind of fun to find the unexpected. So Do I have it here? I guess not. Oh yes, here it is. Nope. I thought I had brought in a bicycle helmet.
Oh,
You know, if you put on a bicycle helmet as your cap, it's going to protect you from shocks. But you're going to, and you don't know how far you'll go once you put on a bicycle helmet. And actually, flogging the metaphor a little bit, we need to have our own protection from shocks when we meet with clients. And most of us, I mean, we hear a lot of stuff. And if you're being traumatized while you're working with a client, what do people do when they get traumatized? They go back to their most overlearned habit. And the most overlearned habit might be, well, let's look at the kinds of thoughts that you're having. You know, you're distorting your thoughts. Or it might be to, well, it sounds like you're feeling upset. And which most clients will go, well, yeah, duh. You know, empathize. Now, we should always be empathizing, but that doesn't mean being mechanical, and it doesn't mean being touchy-feely. It means being genuinely interested in being with the client and experiencing the world through their eyes and feelings. So you get some taste of what it's like to be there. And that also gives you some, and everyone's different. Everyone has something interesting about them. Everyone has some experience that you have not had, which can be a source of wonder, actually. So to enter another person's world, it's really quite a privilege. And it gives you access to, well, where are they? So before we started recording, you and I were talking a little bit, and you were saying that very often trainees are having problems because they're working with clients who are at the pre-contemplative stage of change, and they're trying to change them.
right.
And
I did that too. So it's anybody who's novice. It's, you know, it's very, very common, right? You know, and they want to run consults, and it's pretty obvious that it's a pre-contemplative stage of change.
Yeah. So I would say that the people who cured me of trying to change people who were not ready to change yet were my two daughters. I mean, any parent.
Have a big slice of humble pie, you know, of like, yeah. I mean, actually, I'm very curious about that. Like, you know how you're talking about being genuinely curious about people and really feeling that this is a privilege to enter somebody else's world, and they've had experiences that we haven't had, and it's not ours to fix. And I mean, I mean, if I had $1 for every time I said about entering somebody's world, be a rich person here. But how do we? I don't even know how I got there. Like, I mean, you did mention at the 10-year mark of being, you know, burned out and thinking I would do something different. But yeah, how can we help people get there to recognize that fixing people or trying to change them or over-owning that it's yours to fix when it's somebody else's life? How do we help our clinicians? Because that's not the message they've been given most of the time all the way through graduate school and training.
Right. Well, one way, I'd say there's a number of aspects to that. My friend Moshe Talmon, who literally wrote the first book on single session therapy, when he trains therapists, has a saying, and he says to each therapist, just remember, therapy is not about you. And all of us as therapists put our egos on the line. Oh, I'm going to be successful as a therapist, and or I'm not successful as a therapist. Boy, is that a trap.
Yeah.
I remember one thing which helped me with that.
Okay.
I was in my pre-doctoral internship, and I happened to share an office with a woman whose uncle was a therapist. And I was enamored at the time with family therapy and Sal Minuchin, and I'd just seen this amazing videotape of Sal Minuchin doing this amazing stuff with the family. And I was talking about it, and my friend said, oh yeah, Sal, Uncle Sal, that's my uncle. I went, Sal Minuchin is your uncle? Wow. I mean, he was so amazing in this tape. And my friend said, oh yeah, I remember when Uncle Sal was trying to prepare that tape. He went through like 70 tapes before he found one where he thought he looked kind of good. And, you know, they don't tell you that in graduate school, that the stuff that you're looking at is kind of, okay, this one's worked pretty well.
That makes me feel so much better, because Dave and I just shot demonstration video, and there's a few things that I would have done differently if I could do it, over again. And we're like, we're not editing it, we're not reshooting it, we're putting it up. So that just, I don't know, quells my anxiety, because we just shot it this weekend, and I was like,
in relationship to that, when we did the single session therapy research, we were working at Kaiser, and Kaiser decided to make a training tape. And we used actors for patients and a transcript of an actual therapy session. But since the patients were actors, we got actors to portray therapists, because they know how to be. And so we watched the transcripts of these cases where we were the therapists, but these actors were performing.
Yeah. Oh my
we
gosh.
got terribly depressed, because we said, they're so much better than we are. I mean, they were using our very words, but they would phrase everything just so well, and and pause at just the right place, and make eye contact, and we could never do it like that.
That is wild. But I mean, you're onto something though, of what we're saying about this overowning, and we're watching training videos, and we think we have to be perfect, and we're being hard on ourselves. And now, like, we're overowning, we're making it about us. So what ended up, when you had that moment of being like, oh yeah, it took them 70 takes to get that. Is that when it hit you? Like, oh my goodness, I got to just show up in my.
Well, showing up, 80-90% of it, it really is. I think it is something you learn with experience. I think most of what we learn about technique is very useful, because it gives us something to do to alleviate our anxiety.
Wow.
We know from the research that technique is a minuscule part of what leads to change in therapy. And all the research shows, everyone says, well, it's the relationship. And actually, the relationship's important, but that's not the most important factor. All the research shows the most important factor is the client, and events in the client's life that nobody has any control over. So this idea of control is a little bizarre.
Right? Yeah, when you really put that in perspective, like client characteristics, patient characteristics, rapport, and then technique. And like you're saying, the technique might be more to quell our own anxieties so that we can show up in a way so that we're not so anxious about what am I going to do? What am I going to do? That the patient feels that. Like us having sound techniques might just put ourselves, which will help put them at ease.
Yeah. Yeah. And then having a lot of experiences of failure is very helpful, especially when a client comes back afterwards and says, that was such a helpful session, the last session. And you're going, oh.
You're like, that thing, man, I hope that that would just be erased.
Yeah.
Yeah,
Actually, one of the things we found in our original research on single session therapy, and we videotaped all the sessions, well, not all the sessions, a lot of the sessions, but sometimes we'd say, wow, that was such a great session.
That's what I was just going to say. Yeah,
I can't
it's the
wait to see
opposite.
the outcome. And what we found was what we thought were great sessions were not necessarily what clients thought were great sessions. And the sessions which had the best outcomes were generally very ordinary. Very ordinary. But we fall into the heroic myth. If it's dramatic and heroic, it's gotta be good.
Right.
But that's good for TV and for movies. But in real life's messy. And actually, physicians have a pretty good sense of this, because very early on in your career, you discover that most clients don't fit the textbook model. They usually have 5 or 6 things going on, not one clear thing. The one main thing that's going on usually doesn't quite fit. I actually have a friend who's a biostatistician, and he shows me data plots of various symptoms and whatnot, and they're just scattered all over the place, so that a person who's depressed this way but doesn't have this symptom, but has this other symptom, but has this thing, but doesn't have this thing, and it's like, but you're not fitting the book.
Right.
And physicians see this all the time, and I remember I was trained to prescribe medications in my doctoral internship. And I remember the first time I had to prescribe, and I met with my supervisor, and I had looked it up, and there wasn't any clear thing of, okay, for this particular problem, this was a psychotic young woman, do you use Melrose, do you use Thorazine, do you use Haldol, do you use blah, blah, blah? And I found as much research as I could, and I said, well, maybe such and such. And my supervisor said, well, I've been having a lot of good luck with Haldol lately. I went, good luck? What do you mean good luck? Isn't there something which says this matches with this? And no. And it's very common in medicine. Say, well, let's try this. Oh, did that work? No. Well, let's try this instead. Oh, that did work. Oh, good. And a lot of medicine is just response to intervention.
Right.
And so in therapy, actually within a single therapeutic session, what you want to do is constant response to intervention. You make a statement, and if the client goes, no, go, let's not go that path.
Right.
Instead of, a lot of us will go, oh, well, let me try that again.
Yeah, let me triple down on it.
That's right. It's like, okay, well, that's not working. Let me try this one. Oh, let's try taking it this way. And so it helps to enjoy flexibility and to enjoy being useless.
Yeah, that's I think I do, I think I do know what you mean. It's having that humility that of just going in, right? Like that most commonly somebody's going to be reacting to things in their life and things that they've gone through or their own characteristics. And sometimes what we can say is an ordinary thing that's really profound. Sometimes just being there with somebody, sometimes just reflecting what they're already telling you can help connect things, and to not put that pressure on yourself, because when you do put that pressure on yourself, the only thing that the patient feels is they feel that pressure too. And they
Yes.
can tell that you want to fix them,
Yes.
and ain't nobody want that.
That's
Don't
right.
nobody want
That's
to
right.
be
That's right.
intervened on. My partner in crime, Dave Bauman, says that all the time. It's like, nobody wants to be intervened on. I mean,
Right.
that
Right.
doesn't feel good. Whereas if somebody
No.
walks in and they're genuinely interested in you, you could probably be putting out a completely different, or getting out a completely different behavior repertoire from the patient, one that's might be more flexible, that actually might be helpful. So the irony is, like, knowing you're not helpful can actually help you to be helpful, or knowing you're not useful can help you to be useful. I don't know. It's just
Yeah.
one of the paradoxes.
Yeah. And there are little tricks that I found which can be helpful. So for example, if we always ask a client, well, what have you tried? And then we say, well, did that help? Right. Instead of saying, did that work? To say, well, how did that work? How did that work? Because most things, maybe they help a little, or maybe they have some side effect, but they didn't do anything else. But it's just, oh, you had that side effect. Oh, that's interesting. Oh, well, sounds like the side effect was worse than the disease. And the other thing is to realize most people, and us, we have to be careful not to fall into the fantasy of cure.
Mm.
The idea of,
Yes.
if we can, I'm not going to fix this person, but if I can just help them find their thing, they're going to go off and be healthy. And the fact is, they're going to go off and get another problem. It's just, yes, I can help you solve this problem and get over this problem so you can have a different problem. Isn't that great? That's just what our life is about.
That's so, in all seriousness, kind of taking the, you've been practicing for over 40 years and have, for at least the last 30 years, it sounds like, had really deeply meaningful experiences as a clinician. And, somebody, a listener, might be out there thinking, so wait a second, like a new clinician is watching this and being like, okay, so the key is to be interested, but know that I can't be helpful, but also know that that could be helpful. And that,
No, make it simpler. The
okay,
key is enjoy yourself.
okay,
And if you can't enjoy yourself, appreciate what's happening. The times when you can't enjoy yourself are the times when you go to a colleague and say, wow, I just had the most amazing, difficult, nothing worked. It's just amazing. I'm feeling,
you appreciate that. What about,
yeah.
like you were saying about, if you help somebody with one problem, then they're out in the world, and then, sure enough, as human beings, another problem will arise. How do you, I guess, handle that existentially, almost like from a philosophical standpoint of, like, not owning that, not of finding value in the moment that you had. And if somebody goes off and they have another problem, well, then that's just life. Like, because I could see some, especially a new BHC or a new clinician, thinking, so wait, I'm just going to help somebody go have another problem. I could see how that might be, like, demoralizing to them. What would you say to that? If somebody was demoralized by the fact that you help somebody with one problem and now you just help them to go get another problem.
What's the problem with having problems?
Well, I know.
I'm actually serious about that. I mean, if you think having problems is a problem, that's a problem.
That's a problem.
It's kind of the problem. And here we're up against a society,
That's it. There it
a
is.
societal thing, which I've been consulting a decent amount to university clinics lately, and they have a particular problem in that a lot of students are mostly online in social media, and what people post in social media is all the good stuff. They don't post themselves with their hair all messed up and having a bad day and screwing up, unless it's funny or something.
Right.
So everyone thinks they should be measuring up to the photoshopped, airbrushed, perfect image. I've been looking recently at, I was reading a magazine or the paper, and I just saw some pictures of politicians, and they're all perfect. Their hair, how do they get their hair to look that well? They get $300 haircuts, and the photos are retouched and everything, and so we're trying to match these images, which are that's not real. And I guess the question is, do you want to live a real life, or do you want to create an image of a life? And the problem with creating an image is at some point it's going to wear off and not work. That's just the way it works. So might as well be real and honest. And in my experience, clients feel tremendous relief when you just tell it like it is.
Yeah.
And there's no pretending, and it's just, the other aspect that it's important to mention is, so what about having another problem? It's important to keep in mind that when clients come in with a problem, very often, once that problem resolves, it will leave them room to attend to another problem which they've been avoiding.
Maybe the problem that really needs attended to.
Yeah. And so I will sometimes say, only when it's right, but I'll sometimes say to a client, well, are there any disadvantages to getting better? Are there any, what's the downside of this resolving? And I'll give a simple example. So for a while, I've had a medical problem where I have lung irritation. And because of that, my body very nicely has compensated by tightening all around the lungs so I don't breathe too deep. But then my muscles are too tight. And I'm mostly aware of, the muscles are too tight. So then I learned, okay, relax the muscles, relax. And I cough. And so how to come to terms, this is very common in pain. We guard against the pain, and you have to deal with releasing the guarding, and then you're going to experience more pain. So to look at it clearly and go, well, what's the least problematical problem I can get away with? And aim for that. It's actually that's the whole idea of harm reduction. And I'm a big believer in harm reduction. If you can not solve the problem, but just make it a little less bad, having a little less bad effect spread around, that's great. That's great. A little bit more breathing room. You've accomplished a lot. And often, not always, but often that's enough, in my experience, for people to get some wiggle room and go in other directions.
Right. Yeah, it's the beginning of that ripple. Yeah, that flexibility to take on different frontiers.
It is humbling. It's humbling. It's
yes.
humbling.
And not always what we predict.
Most difficult thing, as I'm I'm enjoying talking with you, and we're probably running low on time. So I want to bring in one other thing. Our minds tend to be very dualistic. I'm either healthy or I'm sick, or I'm somewhere in between, you know. But to get a larger sense of, well, I'm healthy and I'm dying. I mean, that's just true. You know, you're breathing and your heart's beating and you only have a certain number of heartbeats left. So every moment that you live is one less moment that you're going to have. But, you know, we tend to go to one
Right.
side to the other, to the positive or to the negative. And how do you hold both at once? And how do you both feel okay, both succeeding and failing, and realizing there's something beyond success and failure? And actually, we know how to do this. You know, the left eye sees the world differently than the right eye does. And when you have two eyes, it creates a greater sense of dimension. So in meeting a client, there's a saying from my Zen teacher's teacher that I like to hold in mind. He says, "You are perfect just the way you are. And you could use a little improvement." And that's the attitude we want to provide to our clients. You are perfect just the way you are. It's okay that you have this illness. It's okay. Now let's help you feel better. But if you don't feel better, that's okay. And feeling better, that's good. So it's no lose.
Right.
It's just, okay, we can accept this. Yeah, starting with just, let's accept that this is where you are. Let's accept that this is where we are as a medical
Right.
center. And you're here because nothing else is working. Sorry.
Yeah. We don't have anything else to
Got to
lose at this
lose.
point. Yeah, we have nothing else to lose. But patients can feel that on you. You know, they can feel all of these things, and I've found that not having to have the answers and just being able to, not that I'm by any means a master at this, but be able to accept what comes into the room, and not feel this. I don't feel it anymore, and I'm really grateful for it. I don't know if it's all the trainings or what, or experience, or the combination at the right time, or patients teaching me. But entering the room, I feel a freedom. I feel like my only job is to enter their world and to know them. And I just trust that if there is something that we can do, then great. And if there's not, then there's not. And I can't explain in words what it's like to go through my day as a clinician, seeing in many cases, like tomorrow I'm in clinic. I'll probably see 12 patients in a day. I mean, low end, maybe 9, upper end, 12. And sometimes I worry about, like, oh, am I going to get tired? But I don't have any anxiety around, like, well, what am I going to do? And I think that has a lot to do with longevity in the field and dealing with that burnout, and not saying I don't get tired and all those things, but it's not because I feel like patients aren't doing what I'm asking them to do, because I'm not asking them to do anything necessarily, which is crazy, because if you saw my visits or my documentations, you'd see a bunch of SMART goals, and I'm a behaviorist, and we're always doing things. But those things don't have to be anti-theoretical. So I just appreciate you, Bob, and giving your time. You said that you were enjoying yourself. I'm enjoying myself too. This was, I think, the amount of nuggets that and gems that you've left across this entire recording. Hopefully, we're gonna have people going back and hitting pause and going back, or hitting pause, because there was a lot of nuggets in here. I know I'll probably be rewatching it and re-listening to it.
Oh, and can I underline a word that you've used, which I think is really helpful? You use the word freedom, that you're feeling. So if you're not feeling free, the client's not going to feel free. And if we think of meeting with a client not as trying to cure them or help them, but they come in because they're feeling hemmed in and unfree and oppressed by their problem, whether it's medical or psychological. And to go in with the idea, is there any way I can help them just feel a little more freedom, a little more space, to be themselves, to live their lives, just a little bit more,
Just
yeah,
just to be in their skin and
yeah,
not.
exactly, yeah, just that's big. That's big because everyone in our society is feeling oppressed right now and hemmed in. Everyone, the doctors, the patients, the, the everyone in our field. And so to find a way of going, I don't have to feel hemmed in. I have to deal with the realities of the situation, but I don't have to feel hemmed in. Well, but I am hemmed in, you know. Well, yeah, but how do we deal with that in a way so that it feels, you know, like a suit of clothes that I'm wearing, but I can tailor it a little bit to fit, or take off the shirt and put on a different hat.
Right. It's a perfect
And you can even wear the same hat and just, and we can learn
right,
from our clients, right?
right. Man, that's a perfect I feel like conclusion or wrap up. But is there any last thing that is floating through your brain that you feel would be helpful for the audience to hear before we officially wrap up?
Well, I doubt this will be helpful, but I will. So, you know, I'm a Zen teacher, and recently I've been studying a sutra called the Surangama Sutra, and I wrote a book called That Is Not Your Mind. And I will say, I think it is helpful for us to realize that most of what we think is the mind, we don't know what the mind is. And most of what we think is the body, we don't know what the body is. I mean, so if you want to ground yourself in the reality of humility, the body and the mind are big mysteries. We know a little bit. But in this sutra, I got attracted to it because there's a saying, when if can you hear my not hearing? So very often our clients, we feel like they're not hearing us, right? And of course, our clients are feeling we're not hearing them. So the sutra starts off, can you hear my not hearing? Then it says, if you can hear my not hearing, that's obviously not the nature of not hearing, because you're hearing, you're not hearing. So that can't be it. When you don't hear my not hearing, it's obviously not a thing. How can it not be you? Which point you sort of go, what? What? There's a vast world that we are unaware of. And so I'll do this little, this is actually comes from the sutra. So there's a place where the Buddha says, look, you hear the bell?
Yeah.
Okay. Now do you hear the bell? No. You hear the bell? Yeah. Now do you hear the bell? No. We'll try it one more time, the Buddha says. You hear the bell? Yeah. Now do you hear the bell? No. The Buddha says, why do you give such confused answers? You kept saying you heard the bell and then you didn't hear the bell. You're confusing your hearing with sounds. The fact is, when the bell stopped ringing, you could hear it was not ringing.
Oh, interesting.
Your hearing includes sounds and the absence of sounds. Our practice with our clients includes change and the absence of change. Hearing and not hearing, because we're much vaster than what we think is happening in the room. And sometimes something happens in the room, great. Sometimes something happens in the room and it has terrible effects. Sometimes nothing seems to happen in the room, and 3 years later, client goes, and you've just planted a seed. So don't think you know, is basically what it comes down to. And feel comfortable with that and curious and enjoy yourself. That's all.
Yeah. There's no need to over-own. There's no need to put limits on what you can or can't do in the, not you as the clinician, but you with the patients, and show up and be humble.
Yes. Yes.
It's beautiful. All right, I'm going to stop the recording. Thank you all for listening. I hope you all had as much fun listening as I did doing the recording here. So huge thanks to Bob. I can't put it in words. So yeah.
Always great fun talking with you.